Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This is the second of a two-part educational series, IL-31 Inhibition for Treatment of Prurigo Nodularis, supported by an educational grant from Galderma. Hosted by Dr. Sarina Elmariah, a board-certified dermatologist and neuroscientist, an associate professor and dermatology director at the Center for Itch and Neurosensory Disorders at the University of California in San Francisco. This second episode, Mechanism of Action and Clinical Implications for IL-31 Inhibitors, features Dr. Shawn Kwatra, professor and chair of dermatology at the University of Maryland School of Medicine in Baltimore, Maryland.
Welcome, listeners, to part 2 of this exciting educational activity on IL-31 inhibition for treatment of prurigo nodularis. This is supported by an educational grant from Galderma. I'm Dr. Sarina Elmariah, a dermatologist at UCSF Dermatology and the director of the UCSF Center for Itch and Neurosensory Disorders. In part 2 of this educational podcast entitled IL-31 Inhibitors for Treatment of PN, Mechanism of Action and Clinical Implications, I'll be talking with Dr. Shawn Kwatra, who it's a pleasure to be here with and is, probably doesn't even really need an introduction because he's such a force in this field and in itch in general. But I'll have the pleasure of talking about nemolizumab and IL-31 in prurigo nodularis with him. Shawn, do you want to introduce yourself to our listeners?
Sure, Sarina. Well, I hope you're having a great day. It's always a great day when I get to chat with you.
Thank you.
And I definitely wanted to introduce myself. I'm Dr. Shawn Kwatra. I'm a professor and chair of dermatology at University of Maryland School of Medicine. And I love prurigo. I love talking about it and thinking about it. And I love picking your brain about it.
Yeah, I mean, maybe I can even share this on this podcast, but I remember several years ago, maybe not quite 10 years ago, where you said to me, I think we can tackle prurigo nodularis. And I was a little bit incredulous at the time. I was like, I think that's going to be one of the hardest things, but, more power to you for trying. And look at that, not even 10 years later. And I think, the field has changed so dramatically thanks to, yourself and some of our other colleagues, but just such an exciting time for us, right? With PN,
isn't it wild? Like the in just a few years, the journey from nothing that works to then multiple approved options and a filled pipeline. Isn't that kind of wild?
Yeah, no, it's amazing. So let's jump in because, in our first episode, we talked about nemolizumab just briefly. It's the first and only IL-31 inhibitor that's approved by the FDA now to treat prurigo nodularis. We are going to do a little bit of a deeper dive now, and we're going to talk about the mechanism of action of nemolizumab, and we'll discuss, how it works, why it works, what the data showed in the trial. So, nemolizumab, as I'm sure some of you are familiar, is a monoclonal antibody that antagonizes the IL-31 receptor alpha. And that is a receptor that is expressed on nerves and on multiple cell types in the skin, keratinocytes, granulocytes, fibroblasts, and therefore plays a pretty important role in regulating the neuroimmune axis, right? And diseases where there may be keratinocyte dysfunction, fibroblast dysfunction. Shawn, tell me what your thoughts are on how nemolizumab or IL-31 receptor inhibition or antagonism really modulates the neuroimmune response.
Yeah, so it's really interesting. IL-31 is a very fascinating cytokine, oftentimes labeled as a master itch cytokine. And I know there have been a lot of mouse studies that I know you've paid a lot of attention to and worked on, and I'm very interested in as well, that have shown that if you inject IL-31 anywhere in a mouse, then they have a direct dose response increase in itching. And to me, that it's really fascinating that IL-31 almost has a neurotransmitter-like capability for itch. But what do you think, Sarina? You have a really strong neuroscience background, so you know this better than I do. What are your thoughts on IL-31 in particular?
Yeah, I mean, I think, that's why, the IL-31 itself has been called the itch cytokine. I think it's one of many factors, right, that that will act on nerves. But certainly we define those agents, any agent, right, whether it's exogenous, whether it's endogenous, like the IL-31 cytokine or even others, that can activate a group of nerves and then cause itching within a very short period of time, like within minutes. We think about that as a pruritogen, right? An itch-inducing substance. And as I said, the IL-31 receptor alpha is actually on nerves, sensory nerves, on itch-sensing nerves, and clearly activates that pathway. Whereas other agents, like even ones approved for FDA approved for prurigo nodularis, like dupilumab, can still actually act on IL-4 or IL-13 receptors. We know that activation of those receptors can modulate nerve activity, but when you throw IL-4 or IL-13 on, they don't necessarily cause itch immediately, right? That's why IL-31, when you inject it, get an itch response, it causes that. So we know that this is really targeting part of that itch pathway. But the other part to really recognize is that IL-31 activation can also act as a modulator. So it's both an inducer of itch and actually a modulator of itch and other sensory issues. And as we talked about even in our first, episode, a lot of these patients, they don't just have itch. I mean, they always have itch, but they can have other sensations. And who knows how exactly all these cytokines, including IL-31, are causing that. But, it's also exciting about, as I mentioned, the IL-31 receptor, as much as IL-31 may be an itch cytokine, right? You better than anybody else can talk about the fact that it's in other places, right? It's also on the keratinocytes, the receptor. It's also on the fibroblasts. And we know for PN specifically, right, that this can be the fibrotic component of this disease is really, it's challenging to get under control. And so I think that's really, it's an interesting part of how this may work. Do you feel like Nemo's doing, or that we're actively kind of targeting across the spectrum of what, causes prurigo nodularis with IL-31 receptor antagonism?
I do. I think that nemolizumab in prurigo nodularis makes sense from the pathophysiology across a number of levels. We know that we have to stop itch fast, and IL-31 blockade certainly can achieve that in record time. I now have several patients that, are just amazing how quickly it can work. So that's great. But secondly, exactly what you're saying. So they're on the fibroblasts. So we know there's an independent action, it seems, on fibroblast activity. And we also know that IL-31 blockade can restore epithelial function and also promote the integrity of the skin barrier as well, and increased epidermal barrier function. So it's coming along a lot of different avenues for being an attractive therapeutic target. The itch, the fibrosis, the architectural arrangement of the skin epithelium, all of these different factors are restored. And like you said, IL-31 is on the nerves, and we know that that's one of the most important things, the most important thing in prurigo nodularis. And actually in the dorsal root ganglion, there was a nice study on single cell sequencing showing that IL-31 is almost a barcode there for itch. It's just present in that area in the dorsal root ganglion for the nerve cell bodies, but also the fibroblasts. Our lab studying the fibroblasts in prurigo nodularis and seeing IL-31 receptor has a really important role there. Interestingly, there have been studies of IL-31 in other fibrotic diseases like scleroderma, which is just fascinating. So to me, I think this is really special. I also think that nemolizumab downstream is able to target some downstream mediators that are important in prurigo nodularis. So STAT6, which is traditionally associated with type 2 inflammation, but also STAT3, which I think is very neatly attuned, our studies have found, in prurigo nodularis. So I think there's something special about the mechanism here, specifically tailored for the biology of prurigo nodularis, and we're seeing it with the clinical trial results.
Do you also see those changes with other agents you may have used in the past, or even with dupilumab? Do you see those changes as well, or is it something that's specific to nemolizumab?
Yeah, I mean, dupilumab is breakthrough therapy. We're very lucky to have a dupilumab FDA approved and actually paved the way for greater disease state awareness of prurigo nodularis, and the drug, works directly involved in sensitizing the neurons as well. So we know there's neuronal activity, and then we know there's really important immune activity also, even with the type 2 immune cell polarization. But we're still behind a little bit in our understanding of the biology of prurigo nodularis, or still uncorking that. And one thing we found is that there's a lot of different subtypes and phenotypes in prurigo nodularis. So I think it is important that we have a number of different agents with unique mechanisms to treat patients appropriately in this disease.
Yeah, I mean, I think that's really such an important part. It's the evolution of our understanding of this disease has been fascinating. You and I did a talk on this, 8 years ago, where we were still getting questions about whether it was a psychiatric disease, right? And now we have, with the onset or with the introduction of dupilumab, the really excellent control some patients get, and now with, nemolizumab, I think really honing in on some of the active peripheral issues and systemic issues that happen with this disease. So let's actually jump into talking about the Olympia trial. So let me just introduce them. So the Olympia 1 and 2 trials were the pivotal phase 3 monotherapy trials that were randomized, placebo-controlled, run over 16 weeks and 24 weeks, for 24 weeks in these patients. But the primary endpoints of these patients who had moderate to severe prurigo nodularis, which means that they basically had to have, at least 20 nodules. They had to have pretty severe itch, right? Like a peak pruritus NRS score of 7 or more, 20 or more nodules in a bilateral distribution. So that moderate to severe disease. They had to have, IGA, investigator global assessment scores of 3 to 4. So we're talking about pretty bad, right? Patients, pretty active patients. And they were randomized 2-to-1 to nemolizumab or to placebo. And they received a loading dose of 60 milligrams and then a Q4-week dosing that was weight-based, right? So if you were under 90 kilos, it was 30 milligrams every month. And then if you're over 90, you'd continue on that 60 milligrams monthly. The primary endpoints read out after 16 weeks in both trials, even though Olympia 1, I believe, went for 24 weeks because of European, kind of the European regulations. But the primary endpoint at 16 weeks was looking at a peak pruritus improvement, a peak pruritus NRS improvement of 4 points or more, right? And an IGA of clear or almost clear with a 2-point or more improvement from baseline. So that's kind of the setup for the understanding the trials. And, when you see it, the data are just so, impressive. Shawn, do you want to talk about that?
Yeah, absolutely. I think you had a really great overview. I also agree. Nemolizumab's program, so this Olympia program,
It's huge.
I think should be lauded. Really important to give praise for this trial, because this clinical trial development program with Olympia 1 and 2 studies, and then also the long-term extension study and the durability study, does represent the largest clinical trial program in the history of the world for prurigo nodularis. Really, that's what it does. That's what it represents. To me, it's a little bit mind-blowing. And I totally agree with you. Some high-level features. So the week 16 endpoints a little bit earlier. We know baseline population, as you said, did a great job of mirroring the results. I think at week 16 showing that results. So almost 60% of patients with that 4-point drop is really, really special that there was such an increase early on. We know there's nodule improvement here. And then also in the 1-year data, we show that, over 70% around 70% of patients are down to IGA 0 to 1. So less than 6
Yeah,
nodules.
cleared almost here, which I think is fascinating. I mean, even like so at the week 16 time point during the active treatment, right? And in the Olympia 1 and 2 trials, about 50% of patients got that 4-point improvement or more in their itch, and about a quarter to a third of patients actually got that IGA success, right? The 0 to 1, which over 16 weeks is insanity to me. In a very positive way. I think that was wonderful. But you know, two things to highlight, right, was the fact that some of these patients in this trial, and now we're seeing it right in our own experience, you know, we're better within 2 to 7 days in terms of their itch being, you know, being able to achieve that 4-point improvement or more, which I think is great. But as you highlighted, you're getting upwards of 70-80% of patients who stayed on therapy for the long-term extension. Right. And those who were even in the placebo trial who went on to the everybody was able to enroll into the single arm active treatment arm with nemolizumab, and it was like 80% by week 52. By the end of the year, we're able to have that 4-point improvement, but also clearance, and getting that IGA right of 0 to 1 just means so much to these patients. So I think it's really, you know, it's just it's nice to see.
This trial also represents potentially raising the bar here, because there's some data on an itch level close to an itch-free state, so less than 2, with around 70% of patients at week 52 in the open label study reaching that metric, which is actually very significant, very interesting data.
Yeah. Well, I mean, the other thing that you and I both know is that these patients are so hard, right, to treat in general.
Oh, difficult. Yeah.
They're really, I mean, they're such a, you know, challenging group of patients, in the sense that in addition to just all their other medical comorbidities, you know, knowing that kind of these are agents, right? Both with dupilumab and nemolizumab, you know, they're very, very safe. And this idea that, you know, we may have to keep patients on med for a year or two to really get to not just to quiet everything down, but to see if there's any way we can really reduce the likelihood of recurrence, right? I mean, that time will tell. Studies are still somewhat ongoing, but I think, you know, this idea that, you know, do we have a safe drug? Do we have safe options compared to the thalidomides and cyclosporins and high dose, you know, Lyricas or pregabalins and things that we've had to give in the past? You know, the nice thing that came out of the Olympia trials and the long-term, you know, extension is that, you know, this drug was really tolerated pretty well. There were very few, you know, concerns or issues, just, you know, some minor, you know, concerns with like headache and like eczema-like events. So whether it was atopic derm, nummular dermatitis, that was a little bit more prevalent in the nemolizumab group than the placebo, but really the safety is pretty remarkable. And I feel great about that with dupilumab and with nemolizumab, right? So that's a good thing. How are you feeling about that?
Absolutely. I feel really confident about the safety. And the first thing that's great is that these patients have a lot of comorbidities. So traditional agents, you know, like methotrexate, cyclosporin, we have to be really careful there with kidney dysfunction, liver dysfunction, which is absolutely more common in this patient population. So to know that we have an agent that doesn't require regular lab monitoring, that has excellent safety data, doesn't affect liver enzymes or kidneys or anything like that we know of, is excellent overall. And if you look at the safety profile of different metrics, there really weren't many things that were showing up here in the safety data, very balanced between the treatment arm and the placebo arm. There was a small number of patients with mostly mild eczematous reactions that were treated with topical steroids, but
I think they were all mild
patients, some mild transient, you know, headaches or other things that we see in these trials, but really nothing worrisome in any way. There's no warning. There's no lab monitoring. I mean, this is what we like to hear. You know, dermatology in general now, we're having to see lots of patients in our sessions. And so this helps us a lot too, because sometimes it can be difficult to keep track of all the regular monitoring and all of that. So I think it's a huge advantage.
Yeah, and I agree. I mean, it's just one less blood draw that some of these
Yeah.
patients have to go through when they're already, dealing with other things.
Yeah.
A couple other things that also just came out of the trial data was the fact that, and I think we both have seen this in our current, maybe limited, but our current experience with this is, the itch gets better, and certainly the nodules are kind of following. You always say that, right? The itch get better, and then the nodules follow, and I think that's been true so far. But really, like, sleep is such a major, factor. Overall outlook, the anxiety, depression, that there's such a high rate of comorbidity with this. I've had patients who've already called me to tell me, how just much more optimistic and, like, I mean, really happier they've been feeling. They feel like their mental health has improved just because they're also sleeping more, right? So, I think that that's something that they also did look at in the trials and showed benefit, from a sleep perspective, DLQI scores, like quality of life, burden of disease, improving as well. So really, I think exciting times. Do you have any other comments, like just on your any of the ongoing studies or investigations you may even be doing with Nemo, or from what you've heard of with that?
Yeah. So the long-term extension study is continuing, and we're going to have probably 2-year data to report soon, which is really excellent. That we're going to be having long-term safety data in prurigo nodularis. Anytime these studies are conducted, especially in PN, we need that data to really understand the disease better. So that's one that I'm really excited about. They're also going to get more data about the durability study. Actually, from the phase 2 study, patients were given injections at week 0, 4, and 8, and what we saw is that of over 50%, there's over 50% reduction in the overall itch reduction that was maintained at week 18. So over 10 weeks there, that the itch was maintained. So that also highlights there's potential for some durability in the response, which is very interesting as well. So we're going to be looking.
I'll be honest, that's way sooner than I thought
Yeah.
you would see that. I always tend to be a little bit conservative in my projections or expectations for these PN patients. I always feel like longer is better. And I say that as a reflection of my experience for so many years trying to target neural and immune dysfunction in these patients with what I consider kind of big guns. But to see that type of durability already is pretty impressive. So that's great. Well, what are your thoughts now? I mean, this is an evolving landscape. I mean, if anybody's in the heart of it, it's you. So what are your thoughts about even other agents that, there was vexarelimab, which is the oncostatin M receptor beta, antagonist that also blocks IL-31 signaling, that showed some positive results, I think, in their phase 2. What's going on with that?
Yeah, so vixarelimab is a oncostatin M receptor beta inhibitor. So we know oncostatin M is also a pruritogen. And there was positive data in the phase 2 trial for vixarelimab. I haven't heard much, and I don't believe there's any phase 3 study planned. They may have been more of a commercial decision. I'm not aware, but I haven't heard of a phase 3 trial for that. But it did have some positive data, and that makes sense because it also blocks oncostatin M, which is a pruritogen as well. And then in terms of
a pruritogen and a sensitizer, right? I mean, that's the important thing. You're activating this heterodimer, right, of the IL-31 receptor, of the oncostatin M receptor, and it kind of solidifies that idea, right? These things can act as pruritogens, but they can also act as neural sensitizers so that your nerves then respond more to other pruritogens. So, that is interesting that data worked. And the fact that, if using a drug like vexarelimab had, even if it's not, further in development at the moment, it does reinforce the, this pathway being really critical, I think, for the evolution of PN.
Really just fascinating, the number of new drugs that are going through trials.
Yeah, it's great. And the nice thing, I've always kind of said this, like before we had to pull from multiple agents that would target the neural aspects versus the immune aspects. Now we have agents that seem to have these effects, and I would throw the JAK1 inhibitors in there, but certainly with the monoclonal antibodies directed against cytokine signaling or cytokine receptors, obviously they clearly play a role both in nerves and immune aspects and potentially fibrotic, disease or aspects of the disease. And I think when you're hitting all of those key components, that's why these agents have been so helpful, I think, in transforming, the PN landscape. So that's great. Let me ask you a practical question. So you said you have a couple patients on nemolizumab yourself for PN. What have you seen with this? What's your feedback been from your patients?
Yeah, I mean, overall, it's been incredible, fast. So I had some patients that are itching 10 out of 10, and it was one patient there also had chronic kidney disease. So, couldn't give him cyclosporin, and they got the drug, and they had hundreds of nodules and terrible 10 out of 10 itch. And the patient was just, not in a good mood, because who would be? They're not sleeping at all. They're itchy. We did an injection. And 5 days later, their itch was down to 0.
Wow. That's pretty impressive. I mean, I've had patients now call me and say, who failed pretty much everything, who have said, even if they've gotten like some benefit, but never really cleared. And I'll say that I've had similar experiences where they just say, my itch is basically gone. And it's, it's just thrilling. And sometimes it's like still stupefying to me. But I think it's wonderful to hear that and to know that you could have these patients that are just responding so well. Now, I will say on the flip side, I've had a few patients who've also improved, but haven't had such a dramatic response. Yeah. It's too early in my experience with this to say, just based on the data, right? I always tell people, just you got to wait a little bit of time. But I think so far, everybody I have put on it has had some improvement. And I think that's, very, very reassuring. Are you having your patients still stay on other drugs? Or are you doing nemolizumab as just a monotherapy?
Yeah, no, it's a great question. I've been probably doing more monotherapy, because it works really fast, I think. So I think it's more reasonable here. But to be honest, I always encourage folks to, if they want to use some topical steroids, potentially that could help them heal faster. I'll offer intralesional steroids to any terrible spots. I'll always be open to phototherapy as well, knowing that it's slower but synergistic. But not so much of a ton of other agents together. I also like to sometimes isolate what's the activity of this drug. So I've been doing a little bit more mono.
Yeah. Well, me too. I mean, I like to have people on the least possible and try to validate, but it is a patient by patient basis. And I'm just curious, so it may be too early to really make this call, but are you considering, Nemo as first line, or are you, and if not, like, what are the characteristics you're looking for that are helping you kind of choose between the different options of this? Like, who are the people that, you would use Nemo in versus like even starting phototherapy and isolated, other agents or Dupy or what have you?
Yeah, I mean, I think are both reasonable, and also, a number of other factors that are important. So I think comorbidities are really important too. So, that's something important to consider as well. I do think that we need to acknowledge that these immune-biased biologic therapies need to be prioritized as first-line therapies very clearly. Now looking at the data and having the randomized control data. So
yeah, I mean, so you're pointing out a really important factor, right? Up until the PRIME trials, right? The PRIME and PRIME 2 trials for dupilumab, and then the Olympia trials, and obviously the others in the evolving landscape. We have had no randomized controlled trials in prurigo nodularis. Everything was off-label therapy. So I certainly think in terms of kind of first line, these really safe biologics are the way to go as first line. And those are things that, you are leading the helm on this, but we're working through, updating those guidelines to, I think, reflect the use of these very effective and very safe treatments. And hopefully that landscape will continue to change. Have you had any issues prescribing it? Have you hit any stumbling blocks yet with nemolizumab? Any pushback at all?
It's always, there's a lot of burden on docs for any of these drugs because we got to make sure we're doing our nomenclature right, but nothing more burdensome than kind of other agents. I've made it a habit now of documenting the itch score for everyone in their chart, their worst itch or peak pruritus, and then also that IGA score, which I think is pretty straightforward. 0 is no nodules, a 1 is less than, or is 5 or less than 6, and then a 2 is 6 to 20, a 3 is 20 to 100, and a 4 is over 100. So pretty straightforward. I actually think for prurigo nodularis, there's a little bit less of that burden than for some other conditions that have more scales, et cetera. And I know that they're expanding it out to other pharmacies. And I think just with time, it'll continue to get better and better.
I haven't personally had any pushback at all, but I'll say that I've gotten, I have heard from a few people that if they didn't actually write down the number of nodules, which I'm hoping that doesn't really continue, but, essentially if you're assessing the severity of the itch, right? So you mentioned the worst itch NRS or peak pruritus NRS, just getting a scale down of how bad it is. And then also like a general gestalt, number of nodules, like a lot or a little, or if you want to do an IGA scale, I agree. It's very easy for PN and probably really important for us to get that down, but it does help with those little bits because 1 or 2 people have mentioned that they've had to actually go back and document the number of nodules. So, I think we've covered a ton of territory, and this has been really wonderful. I want to thank you for all your hard work in this disease, your expertise, everything that you've done to move the needle on PN, you specifically, and your colleagues and a lot of my itch colleagues who I think have done amazing work on this. But also to the larger community to have an interest in this and build an awareness about this disease for our patients who just really suffer so much. So, Shawn, any key takeaways or final thoughts for our listeners?
Yeah, I would say this is a really exciting time for docs as well and providers and evaluating prurigo nodularis patients. We haven't had these options, so it's just very important that we know that prurigo nodularis is a systemic disease. 2/3 of patients are itchy in the nodules, but also normal appearing areas. You can't only treat the nodules. We found there's a lot of inflammation in the bloodstream. There's a lot of comorbidities that may be associated with unchecked disease. So in my mind, you cannot waste time giving topical therapies, expecting there to be results. I have never had a prurigo nodularis patient respond adequately to topical steroids.
Yeah. Never. I would definitely agree with that. And that message is near and dear to my heart, right? Don't, if it's PN, start to treat it, right? And now we have these effective options and hopefully also more to come. So with really very little barriers, I think, in terms of certainly safety concerns, but really just it's something that we need to be more mindful of because these patients suffer. So thank you again, Shawn, for participating in this educational activity. And listeners, if you haven't already, please be sure to go back and listen actually to part 1 of our series, IL-31 Inhibition for Prurigo Nodularis podcast, and learn more about how PN presents, the standard of care for our PN patients, and really, what they are, what these PN patients are dealing with. And for more information on prurigo nodularis diagnosis or treatment, please stay tuned to DermDocs, and you can visit the www.livederm.org to get more of that information. And thank you so much for taking the time to listen today.
Stay tuned to Derm Docs, powered by LiveDerm, for more dermatology education coming to you soon. Thank you.